Today I'd like to introduce Dr. Yusuf Saleeby, JP, from the Carolina Holistic Medicine. Thank you for joining us today, JP.
Then it's always a pleasure.
Okay, I was just going to put your website up here so people can find you. If I can find it, there we are. So it's carolinaholisticmedicine.com. So people can go there and find out all about you. So today you're going to talk to us about cancer and some experiences that your patients have had. So take it away.
Sure. So in 2020, I had two interesting cases of where LDN came through and was a powerful tool. So I'll talk about both of these. The first one will be someone I'll refer to as NM. She's a 55-year-old white female who came into my office in the latter part, the early part of 2020, around March of 2020, with a diagnosis of breast cancer in her left breast. Now she went in for a routine screening after she kind of found a little bit of what she thought was a lump. So they did the mammogram, and then they did a follow-up MRI because they found actually 4 tumors in her left breast, one right under her nipple area, and then 3 more at the very low 6 o'clock region of her breast. And of course, they told her they were recommending a bilateral mastectomy and possibly oophorectomy after determining if there were estrogen, progesterone positive tumors. And also they wanted to do chemotherapy and radiation. And she's more of a holistic approach to her health, and she wanted a second opinion. So when she came to me, we were talking about alternative treatments for her cancer to see if they would work. So she basically kind of put off her oncologist a little bit and put off the surgery. They insisted on 2 agents. One was called Herceptin and the other one was called Progetta. And those are IV infusions. So they insisted on giving her that to at least stop the further growth of these tumors while she was kind of making up her mind. And I had no objection to that. I kind of said, well, let's try some more natural things first. But her oncologist convinced her at least to do the Herceptin Progetta in pre kind of surgery, radiation, full chemo. So we started her on LDN, and I did a kind of a fairly rapid acceleration from 1 milligram to 4.5, over a shorter period of time. I wanted to get her on that. We also used a nighttime dose of melatonin, and I also used metformin. So metformin is a drug that's used in a lot of diabetics. It's probably one of the most prescribed type 2 diabetic medications in the world. And in Europe, it's finding its way into oncology to help with cancers. Metformin is kind of an interesting drug. It's used in polycystic ovary disease, in insulin resistance. It's used on a lot of different things. Fertility, they use it in fertility medicine. So it has kind of this hormone effect. So anyway, that was her cocktail for me, melatonin, LDN, and metformin. And she was on that for about 3 months. And then she went for a follow-up, and they decided to do surgery in August. Actually, August 7th of 2020 was her surgery, where they were going to go in and remove those 4 tumors. And when they got in there, of course, they used ultrasound to kind of place needles. They had a hard time finding them again. They were kind of not as large as they expected. So the surgeons went in, and then they kind of fished around for a while, and they removed some tissue that they thought was going to be the cancer tissue. And when they sent it to pathology, the report came back, and all 4 samples of all the masses that they removed from her breast had no evidence on examination, pathological examination, of any type of cancer. So when she followed up with her oncologist, a week after the surgery to look over the report, her oncologist was a female oncologist, walked in the room sort of in disbelief and was holding the report and said, I had to read this 3 times because I didn't believe it, that there was absolutely no cancer whatsoever found on those excisions that they made, that the biopsies they removed. And this was biopsy proven by needle biopsy when she had her first mammogram. When they first discovered those lesions, they did do a small biopsy of the tissue, and it did prove to be cancerous. So it was not like a false diagnosis in the beginning. So they did not attribute that loss of that cancer, the disappearance of that cancer, to the Herceptin or Perjeta. It just doesn't work that way. But they wanted to, at one point, to do full-on courses of chemotherapy and then a radiation therapy. And so she, of course, refuses. Well, if there's no cancer there, I shouldn't do that. And they said, well, yeah, maybe you're right. And but they said, well, let's do 6 more rounds of Perjeta just in case. So she comes to me for a second opinion. And I said, well, if there's no cancer, I don't see the utility of even doing Perjeta for another 6 rounds. I mean, it's ridiculous. So we've now kept her on. We've discontinued the metformin. And now she's on nighttime dosing of melatonin, higher dose, around 10 milligrams. And she's on LDN 4.5 milligrams. And I'm recommending that she stay on that for life. So that was a very great case. We celebrated the fact that there was no cancer and there was no need for any further chemo or radiation with this woman. The only other thing I added was hinokiol, which is an extract of magnolia bark. That's been shown to be helpful in suppressing cancer. So she's really on LDN and hinokiol, but definitely LDN for life.
But not only is that such an amazing story, but how quickly. I mean, the speed in which it worked was amazing.
That's correct. I think it had me even a little bit shocked at how quickly. I was expecting the surgeon's report to say that, they removed some cancerous tissue and it was much smaller, because again, her repeat ultrasound, it seemed to have shrunk in size just by the ultrasound, comparing it when she was first diagnosed to the second diagnosis. But we were all kind of pleasantly surprised, at least I was, in telling them, letting her know that, she didn't have to go through any more, any torment with IV chemotherapy or even radiation. So the other case I'd like to discuss is a male patient. I'll refer to him as FR. He's 62 years old. He went in for a screening colonoscopy and they found a mass right near the rectum, which they suspected was rectal cancer. So they did a biopsy and for sure it came back rectal adenocarcinoma. And at that point, it was stage 2 rectal CA. And of course, they recommended surgery, possibly by other chemo. And they told him that because of the size of the tumor, that they would probably have to do wide margins, big excision, and would probably have to remove his anus and have a colostomy bag for life. Well, he wasn't too happy about that news. He's a pretty active fellow. He looks younger than his stated age. And he had a lot of energy, and he wanted to, he didn't want to be restricted by having a colostomy bag for the rest of his life. So he came to me for a second opinion. And he was also working with another local acupuncturist who was doing some other therapies too. The acupuncturist wasn't in our state able to legally write any of the prescriptives. And again, I put him on a cocktail similar to the first patient I talked about. So we put him on LDN, and we rapidly, again, got him up to a therapeutic dose of 4.5 milligrams. And we were also using metformin. He was also getting some acupuncture treatments and some other IV therapies at the acupuncturist's office. So the surgery was scheduled for March of 2020. And when the surgeons went in, again, they warned him. They said, look, the way that tumor looked back then and how we project it's going to be grown some because you delayed your surgery. Part of the reason the surgery was delayed was because of COVID. A lot of the elective surgeries and things like that were canceled or postponed. So it wasn't only the fact that he wanted to delay it to try to give these other therapies some time to work. it was also because of the pandemic. So when they had him getting ready to go under the knife, they told him, like, this tumor is probably going to be a lot bigger than we first saw it, and we're going to have to take wide amounts of tissue for good clean margins. We're going to put in a colostomy bag, and we might have to remove your anus, and so that might be a lifelong thing. So when the surgeons actually got in there, they were quite amazed to find out this tumor, which was probably the size of what they initially described as the size of a walnut. It was now about the size of a green pea. It had shrunk so much.
Mhm.
It didn't completely go away, didn't completely disappear, but he was able to salvage his rectum and anus, and they just did a smaller excision and got clean margins. They did put in a colostomy so that could heal, but his colostomy was only there for maybe 3 or 4 months. It was reversed successfully, and now this patient is able to use the restroom like everyone else. And at this point, we have him only on low-dose naltrexone at 4.5 milligrams a day. So that was a success story because we made his whole life. It was a life-altering thing. I mean, if we didn't shrink that tumor down, he would have to have an external colostomy bag for the rest of his life. And now he can lead a normal life. He can go swim in the ocean without worrying about things like that. So those were 2 cases in 2020 that are very memorable in our practice for the use of LDN in cancer as a cancer therapy.
What other cancers have you treated in your practice over the years?
Well, we've treated a number of breast cancers. We've treated some thyroid cancer. Because I specialize in thyroid disorders, we tend to get some folks who've had previous history of thyroid cancer and thyroidectomies, radiation, ablations. We've treated a fair amount of breast cancer, some colorectal cancers. We had a couple of folks come to our clinic, one with pancreatic cancer. Well, actually two ladies with pancreatic cancer. One was fairly young in her early 50s. The other was a woman in her approaching 70. But because they came to us late, a lot of times folks don't realize they have options. They go to conventional mainstream medicine and they get put on the regular practice guideline recommendations for oncology, and they don't realize there are other options like LDN and metformin and some of the nutraceuticals that we use. So these 2 patients that came into the practice had late stage pancreatic cancer, and unfortunately they both expired, and that was unfortunate. I think had we got a hold of them earlier, may have made an impact. But a lot of times people come to us in the final stages with the prognosis of they have maybe 2 or 3 months to live, and they get very desperate, and then they start seeking out centers like us to help them, as a last-ditch effort, and it's not always successful that late stage.
Hearing the diagnosis, you've got cancer, is devastating. I was there with my mother when she was told, but she had lots of other problems and there was nothing they could do. But, if you're a young person and you've still been told you've been diagnosed with cancer, it's still really hard to take. And then if you're offered all these things that you probably haven't had to learn about, investigate, chemotherapy, radiotherapy, people have heard of them. What do they actually do to you? When you have an expert oncologist who deals with cancer in the Western style telling you these are the treatments you need, it must be quite difficult to say, wait a minute, I would like to try something else, something that they don't know about, don't necessarily believe in, to go against them. So what I'm trying to get to here, if somebody is diagnosed with cancer, and they feel that the traditional medicine route is not possibly the route they want to take, how is the best way to go down the more natural alternative route?
Right.
What would you say?
So while oncology is not my main focus and my main specialty, I do work with traditional oncology. I currently have a patient who I just saw recently within the last month for a follow-up. So she and her husband came to my office initially. They had been diagnosed with breast cancer, and oncology wanted to do some chemotherapy and radiation. And also maybe some hormone therapy, like tamoxifen or something similar to that. And they came to me for other opinion. And I basically told them, I said, well, maybe you need to get a second opinion from an other oncology group just to make sure that the recommendations are the same. Because they were recommending a course of chemo called AC, and their second opinion doctors mentioned something called ACT, different sort of a combination of chemotherapy. Now this couple, they were kind of hell-bent on doing the conventional chemo. So that wasn't anything that they were going to exclude completely. They wanted to embrace it, but they wanted to make sure they were getting the right regimen. So I started them on LDN. I started them, and the only time we broke the LDN was when she went in for surgery, because we figured they would use opioid analgesics post-operatively. So we didn't want it to be blocked. So she was only off of it for a few days. She resumed it. She was on hinokiol. She was on higher doses of melatonin and metformin also. So she maintained that with me, but she decided to go on and have chemo. So really the next time I saw them was almost 6 to 8 months later, because they had gone through the surgery. She had a bilateral mastectomy, then followed by chemotherapy. She did have some axillary nodes that were positive. So they did a major surgery, followed by several rounds of chemo. So I only saw her after that was all finished. I mean, her hair had fallen out, so her hair. But we discussed that situation, and actually they went and had a third opinion. So after they left my office, I recommended a second opinion by a different oncologist, but they went further and went out of state to a big, I think it may have been MD Anderson, and they got a third opinion from a fellow who had published a lot of material, and that was the tiebreaker for them to choose ACT versus AC alone. So at least I gave them credit for doing their homework. They were very diligent about doing their homework. He was an engineer, very meticulous about fact finding, but they also understood the utility of the other side, the more alternative treatments like LDN. So they are planning on staying on the LDN and foregoing any of the therapies, hormonal therapies.
Mm-hmm.
Because her tumor markers did not pan out for use of those actually. So we decided to be more conservative and not use those things that could maybe change her mood and set her up for osteoporosis and a few other things. So we decided to kind of lean more post-surgery, post-chemo on LDN than on any of the other pharmaceuticals.
Mm-hmm.
So,
I mean,
again, just
it doesn't have to be Western medicine or alternative. They can actually, work together, but you need to find an oncologist that's prepared and open-minded to use these other therapies. I don't know whether you listened to Dr. Akbar Khan talking about treating cancer patients. He always treats it from every angle, whatever you can throw at it to get the patient to the other side of being cancer-free. He will explore every avenue. And I think, what have you got to lose, by trying everything?
So exactly, and I've heard Akbar Khan talk a number of times. He's a great great guy. He gives great lectures on LDN and cancer therapy. But I agree with him. I think I'm of the same mindset in that they're not mutually exclusive. You don't have to pick one or the other. You don't have to turn your back on some of what functional medicine and integrative medicine offer to go with the mainstream medical oncology. I think it's silly not to use both. I never discourage someone. I will never bring someone into my practice and say, oh no, don't do this, don't do that, only do this. With me, I will tell them to do their research and their homework on hormone therapy, on radiation, because there's so much collateral damage with radiation. And even with some of the chemotherapeutic agents, I mean, that can make somebody a cardiac invalid with the destruction of myocardium. And so they have to realize, they have to be educated. There should be a good bit of informed consent before they just, go that way. And they may find out by maybe not jumping the gun. We see a lot of this when the diagnosis is first made, especially with breast cancer or prostate cancer. And I've had a couple of cases of prostate cancer as well that worked out well with LDN. But the thing is, oncology in the West, especially the United States, they want to make a commitment. So you get the biopsy report, and then they tell people, well, you need to make a decision in 4 days. We want to get started in 4 days. I'm like, 4 days? I mean, we're talking about a slow growing breast cancer. You don't need to make a life-changing decision in 4 days. But there seems to be this urgency to get them committed and locked in, and, for maybe obvious reasons. So I like to take things a little bit slower and say, well, let's give this therapy, let's give the LDN a chance, and maybe the tumor will shrink down where you won't need to go through rounds and rounds of chemo. But again, they're not mutually exclusive. Like the third patient I talked about, she and her husband decided to go the route of chemo, but not going full on with the post-operative treatment with the hormone therapy, because they read so many bad things about it. So I was able to steer them in a direction that would protect them without having to use those other agents that they were maybe concerned about.
In your experience from the patients you've treated, how long would you say it takes LDN to start working? I know it's like how long's a piece of string. It's a tricky question.
It's really patient dependent. I've had some people that are non-responders to LDN, or it didn't work as I had envisioned it to. And then I had folks like NM and FR who had remarkably quick responses to LDN, which was quite amazing. So I never promise anybody anything. I try to rapidly increase the titration. I usually take my time in other circumstances by increasing by 1 milligram every 4 weeks until I get to the desired dose. But with oncology patients, sometimes it's at once every week or every 2 weeks, I'll increase the dose, starting at 1 milligram up to usually 4.5. I tell people to be patient with it. I tell people do not expect a miraculous turnaround in a week's time while you're on LDN. And I know this is off subject, but it might be appropriate for this time dealing with COVID infections. I use LDN in COVID prophylaxis on patients, but in the acute setting, if somebody comes to me and says, hey, I just tested positive for the SARS-CoV-2 virus, can I get on LDN? I'm like, well, I mean, you can, but don't expect it to work immediately. It's, I think, a good tool to use along with the nutraceutical bundle, like the zinc and quercetin and higher doses of vitamin C and D. Along with that, so the patients of mine who are already on LDN for other autoimmune reasons have the benefit of this as a prophylaxis for coming down with this virus. But again, I don't know. I don't have any data to say that, well, if we put them on it on day one where they were infected, how effective is that going to be in the very short course? I don't know that it would be. So I'm not inclined to write an acute prescription for just like, say, 2 weeks of LDN. But if they're already on it, I think they do benefit.
Mhm. Well, that's been really interesting. We'll leave it there and we'll have you back another time and you can share some more experience with us.
Very good. Thank you, Linda. It's always a pleasure.
Okay, thank you. Bye-bye.
Bye.